Mama, nobody's joining. Why? Oh.
Okay, good evening, doctors.
Yes,
Yes,
doctor.
doctor.
Good
Good
evening.
evening.
So, our question is about heart failure drug management, pneumococcal vaccine, influenza vaccine, calcium channel blockers, spironolactone, ACE inhibitors, beta blockers, hydrolyzine nitrates, ACE inhibitors, furosemide, digoxin, electrocardiogram, and echocardiogram. Should be offered annually for all patients with heart failure. Annually is influenza vaccine.
Influenza
Influenza
vaccine.
vaccine.
Yes. And should be introduced first line in patient with stable impaired left ventricular function. So whenever we saw there is low ejection fraction, heart failure or impaired left ventricular function, that is the only time when you have to give some medicines in heart failure. So first line for heart failure will be ACE inhibitors and beta blockers.
AC
AC
inhibitors
inhibitors
and
and
beta
beta
blockers.
blockers.
Yes. Has only been demonstrated to improve mortality in patients with NIHA class 3 or 4 heart failure who are already taking ACE inhibitors. We already did this question the other day.
Yes,
Yes,
spironolactone
spironolactone
has
has
only
only
been
been
demonstrated.
demonstrated.
Digoxin.
Digoxin.
Improving mortality. No, digoxin and diuretics, 2Ds do not improve mortality.
Yes,
Yes,
Improving
spironolactic
spironolactone.
mortality
is
is spironolactone, mineralocorticoid receptor antagonist.
I
I
think
think
we
we
did
did
this
this
question,
question,
sir,
sir,
day
day
before
before
Yeah, I
yesterday.
yesterday.
think we are done. So we are doing it again. So if at all we face two or three questions which we have repeated, we'll just quickly do the answer and go ahead.
Yes.
Yes.
A 75-year-old woman presents to a general practitioner with breathlessness and leg swelling. She has heart failure, ejection fraction 33%. Rheumatoid arthritis, type 2 diabetes. Her medications are 7.5 milligrams bisoprolol daily, 10 milligrams lisinopril once daily, 20 milligrams furosemide twice daily, 50 milligrams, 500 milligrams metformin 3 times a day, and 1 gram paracetamol 4 times a day. On examination, she has mild bibasal crackles, heart sounds are normal, and there is bilateral pitting pedal edema. Heart rate is 72 beats per minute and regular. So heart rate is 72 and regular. Respiratory rate is 18 breaths per minute. Oxygen saturation is 94 on room air. Blood pressure is 124. Her temperature is 36.2. It's all fine. So what is less? Oxygen sat is less. Bloods from appointment 2 weeks previously shows sodium 140, potassium 4.2, bicarbonate 23, urea 6.2, creatinine 114. All of them look fine. What is the most appropriate medication to start? Our options are amiodarone, spironolactone, digoxin, ivabradine, amlodipine. So, first line medication, ACE inhibitors and beta blockers have been given. Okay. Second line medication is spironolactone. Third line medications are digoxin and ivabradine. So now we have to go for second line medication because see her heart failure is not compensated. See bibasal crackles, that is she has pulmonary edema and also she has bilateral pitting edema. And
Ejection
Ejection
fraction
fraction
33.
33.
so you need to give her a medicine to complement her medication list. So I think it is spironolactone.
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 Okay. Offer a mineralocorticoid receptor antagonist in addition to ACE inhibitors, beta blockers to people who have heart failure with reduced ejection fraction if they continue to have symptoms of heart failure. So heart failures, there are three types of medication. First line therapy, ACE inhibitors, beta blockers. You can start any one and then add the next one. Second line therapy is an aldosterone antagonist or mineralocorticoid receptor antagonist, that is spironolactone. Examples are spironolactone and eplerenone. And also an SGLT2 should be added if it is given in the option because it might show up in your options because it is only 2021 guidelines. So new guideline it might show up. Third line therapy. So irrespective of the fact that the patient has diabetes or not, you will add an SGLT2 inhibitor. And third line therapy would be ivabradine. Why not here? Because the heart rate is 72. Okay. The heart rate should be more than 75 if you were to select an ivabradine. And left ventricular function was 35. So in this case, ivabradine is anyways contraindicated. Sacubitril valsartan, again LVEF is 35%. That's an indication. And digoxin has not proven to reduce mortality with heart failure. However, symptoms improve due to its inotropic properties, strongly indicated there's a coexistent atrial fibrillation. Anyways, it is third line. So all other options. Amiodarone has no role here, right? Digoxin, ivabradine, amlodipine, no role for calcium channel blockers in heart failure. You're reviewing some pathology results at your practice and come across a urine albumin creatinine ratio of for a 67-year-old lady who is normally fit and well. She takes no medication. She also had routine blood tests including a full blood count, renal, liver function which are normal. Urine dip was also normal. Her early morning ACR is 5 and her estimated glomerular filtration rate is more than 90. You call her to discuss the results. According to the NICE guideline, what classification of chronic kidney disease does this lady have? So it is A2 because ACR is 5 and see the options are G1A0, G1A2,
G1.
G1A3, G2A1, G3A, A3. So more than 90 is her GFR, so will be G1.
G1.
Okay, A0 is less than ACR less than 3. Between 3 and 70 will be A2, A1. Huh? Huh?
Yes,
Yes,
yes.
yes.
So
Yes,
Yes,
A1.
A1.
is 1.
G1
G1
A2.
A2.
Huh. There is no A0. G1, A1 is ACR 3 and 3 to 70 is A2 and more than 70 is A3. So I am thinking it is G1, A2. So a patient with an eGFR more than 90 with an ACR 5 has G1, A2 classification of CKD. So CKD is classified according to eGFR and urine ACR. So eGFR more than 90. क्यों disturb कर रहे हो? क्या?
Why is that, like the big one red and the small one green? Why?
Where?
Better.
मत तुम डाउट पूछो जाओ रिकॉर्ड भी हो रहा है क्लास जाओ where were we? An eGFR more than 90, so classified as G1, stage 1. eGFR 60 to 89 is G2, 45 to 59 is G3A, 30 to 44 is G3B, 15 to 29 is Z4, and less than 15 is Z5 or kidney failure. Urine ACR less than 3 is A1, 3 to 70 is A2, and more than 70 is A3. So then you put the two values together and then the patient is classified as G1A1, G2A2. This is not CKD in the absence of markers of kidney damage. So even if it is G1A1 or G2A2, it is not CKD in the absence of any markers of kidney damage. This lady has a normal eGFR and moderately increased urine ACR and she is therefore classified as G1A2. The option 2 is correct. So this is about chronic kidney disease, eGFR and classification. So there is one thing that's important here. Serum creatinine may not provide an accurate estimate of renal function due to difference in muscle mass. For this reason, formulas have been developed to estimate the glomerular filtration rate, estimated GFR or eGFR. The most commonly used formula is modification of diet in renal disease, MDRD equation, which uses the following variables. The variables have been asked again in the exam. So serum creatinine is a variable. So you check only the serum creatinine. You take a history about the age, gender, and ethnicity of the patient. You put these values in this formula for MDRD, which is available online, and then you get the eGFR calculation. So eGFR is a calculated value nowadays. Depends on the serum creatinine value and these variables. So factors which may affect the result are pregnancy, muscle mass. In case of amputees, the muscle mass will be less, total muscle mass will be less, and bodybuilders, total muscle mass will be more. Eating red meat 12 hours prior to the sample being taken can lead to a spurious eGFR measurement. CKD may be classified according to GFR, so we have read all this just now. Your managing a 50-year-old man who presented with continuous shortness of breath. The patient cannot seem to lie flat down. And he sleeps on 2 or 3 pillows. He has a history of taking medication for low ejection fraction heart failure, including bisoprolol, atorvastatin, and enalapril. So now he has a beta blocker, he has a statin and an enalapril. His latest results. So he sleeps on 2 to 3 pillows, shows that there is some kind of
Heart failure.
heart failure.
Yeah.
Some kind of edema, pulmonary edema is there.
Yes.
So sodium 140, potassium 3.8, urea 3, creatinine 70, HbA1c is 40. Your patient has an appointment next week with his specialist. What do you expect the specialist would do? Added digoxin, losartan, spironolactone, consider empagliflozin, spironolactone, consider ivabradine, cardiac resynchronization therapy. So,
I think
yes, doctors.
third.
Third, yeah. Third one, most likely, doctors. That's because see, he's taking bisoprolol and enalapril, ACE inhibitors and beta blockers. He's taking. First line drugs is gone.
Yes.
Still, he's
Yes.
symptomatic. So second line is spironolactone. And just now I have told you the newer guidelines, empagliflozin should be given, even though his HbA1c is within the normal range. Okay, even though it's non-diabetic, you can give empagliflozin because it has some protective effect in heart failure. SGLT2 inhibitors should be considered as second-line therapy in patients with heart failure with reduced ejection fraction in addition to optimized standard care. This patient has a history of chronic renal failure, heart failure, and however, these symptoms are still poorly controlled with first-line therapy. So, it is the correct time to consider second-line treatment and also consider the new recommendation that adds SGLT2 as per new guidelines, regardless of whether the patient has diabetes or not, and irrespective of the HbA1c levels. Okay, doctors. So, chronic heart failure drug management we already know. We have read that. 52-year-old man has returned to his GP for his annual health check. He has a past medical history of hypertension for which he takes Ramipral 10 milligrams once a day, Felodipine 10 milligrams once a day, and Bendroflumethiazide 2.5 milligrams once a day. So hypertension, he's taking ACE inhibitors, full dose, Felodipine, CC calcium channel blockers, and a thiazide like diabetes, 3 drugs. Blood pressure results today are 158 by 89, 156 by 82, 163 by 87. So what is our standard value which we should get is 140 by 90 with medication, right? In case of hypertension, that is our, I don't know what they call that, target value, target blood pressure. So still it is high. So blood tests have taken as a part of health check. Sodium 140, potassium 4.8 is high, bicarbonate 226, urea 6.3, creatinine 115. What is the most appropriate medication to start? So A, C and D are gone. Next medication in line for hypertension. Bisoprolol, no beta blockers, furosemide, indapamide. Indapamide is again a diuretic. Losartan, spironolactone. So
It's
next medication.
bisoprolol because spironolactone is for patient who has 4.8.
Yes, bisoprolol. Because either alpha blockers, now the only option we have is alpha blocker or a beta blocker. So bisoprolol would be here. Poorly controlled hypertension, already taking ACE inhibitors, calcium channel blockers, and standard dose thiazide diuretic. Potassium more than 4.5, add an alpha or a beta blocker. A woman with a stage 3A chronic kidney disease ascends her GP for the results of her annual EGFR. These are the results from the past 3 years. EGFR 2017 it was 59, 18 it was 51, 19 it is 35. So the change is more than 15, right? 35 to 50 is 15 and 1, 16. What is the most appropriate next step in her management? So within a year, her EGFR has changed more 16 points. And step up EGFR monitoring to 3 monthly. Prescribe an ACE inhibitor. Refer to a nephrologist. Urine dipstick. Step up EGFR monitoring to 6 monthly.
Refer to nephrologist.
Yeah, even I think that is referral to nephrologist, but we need to see the answer. Yeah, referral to nephrologist. There are two guidelines actually. NICE guidelines suggest referring to nephrologist from primary care if the EGFR falls below 30 or progressively by more than 15 in a year. So here if it was 30, then also we would have referred, or maybe in 2020 if it was 30 and this was not so wide, more than 16 points, we would have referred, or because here 16 point change is there, more than 15 in a year, you have to refer to a nephrologist. These are the two criteria for referral to nephrologist. And I recommend arranging a referral to nephrology specialist if there is an estimated EGFR of less than 30, a sustained decrease in EGFR of 25% or more, and a change in GFR category or sustained decrease in EGFR of 15 ml per minute or more within the last 12 months. So let us see each of them. So a change in GFR category. So this one is 30 to 60 comes under 3, category 3, and so 51 comes under 3A and 35 comes under 3B. So there's a change in category of GFR also, and there is sustained decrease in EGFR of 15 ml per minute or more. Yes, there is a decrease within the last 12 months, or sometimes they have given value and you have to calculate whether it has decreased more than 25% or not. Okay, and if it is decreased more than 25%, then also you have to refer to a nephrologist. A urinary albumin creatinine ratio of 70 milligrams per mole unless proteinuria is known to be associated with diabetes or is managed appropriately. So whenever there is a urine albumin creatinine ratio of more than 70 in any category of kidney disease, like even if it is stage 1 and ACR is more than 70, then you have to refer to a nephrologist. An ACR of 30 milligrams per millimole or more together with persistent hematuria after exclusion of UTI. So this is another criteria. ACR is more than 30 and persistent hematuria is there. Hypertension that remains uncontrolled despite of the use of at least 4 antihypertensive drugs at therapeutic doses, that is true. So 4 drugs, resistant hypertension, refer to a nephrology specialist. A suspected or confirmed rare or genetic disorders of CKD, cause of CKD such as polycystic kidney disease, suspected renal artery stenosis, suspected complication of CKD. So this one only says the GFR categories, nothing else in the explanation. Betty is a 79-year-old woman with chronic, maybe we should have this in the group. Okay, next question. Betty is a 79-year-old woman with a chronic kidney disease and hypertension who has booked in to see you for a medication review. She is currently taking Ramipil 2.5 once daily and amlodipine 5 milligrams once daily. Her blood urine test from last week are as below. So she has CKD and hypertension, taking ACE inhibitors and calcium channel blockers. Nothing about her BP. Sodium 138, potassium 4.6, urea 8.2, creatinine 135 is high. Urea is also high. EGFR is 39. Okay. Urine albumin creatinine ratio is 73. Taking into account the above results, what should her target blood pressure be according to NICE guidelines? So chronic kidney disease target blood pressure would be 130 by 80, right? What category is she in? 39, that is 3, category 3. We were having this last time we have discussed this and shared in the group, doctors. Anyone remembers exactly? Okay, let's see the answer. 130 by 80. Aim for a lower blood pressure target less than 130 by 80 in patient with chronic kidney disease, hypertension, and a urinary albumin creatinine ratio of 70 or more. So all these three conditions were there in this patient. So CKD with hypertension and urine ACR of 70 or more, your target blood pressure would be less than 130 by 80. Treating a high blood pressure in a patient with chronic kidney disease conveys benefit of reducing cardiovascular risk and slowing the disease progression. If her ACR was less than 70, then the blood pressure target would be 140 by 90. Since all of these, if they are satisfied, then the blood pressure target less than 130 by 80 is recommended. ACR was less than 70, in this case, less than 140 by 90 would have been the target. Target for home blood pressure monitoring readings is less than 135 by 85 in those under 80, and for those over 80 without comorbidities, the target is less than 145 by 95. And if a patient were over 80 without comorbidities had a clinical blood pressure less than 150 by 90, then you could consider not treating with antihypertensives according to NICE guidelines. So this is normal. Over 80, 150 by 90, less than 150 90 is taken as normal. So no need to give any antihypertensives. So chronic kidney disease and hypertension. So we have very brief guideline. Majority of patients with CKD will require more than 2 drugs to treat hypertension. ACE inhibitors are the first line and particularly helpful in proteinuria renal disease. So she's already taking ACE inhibitors, proteinuria renal disease, diabetic nephropathy. As these drugs tend to reduce filtration pressure in a small fall in glomerular filtration pressure and rise in creatinine can be expected, NICE suggests that a decrease in EGFR up to 25% or a rise in creatinine up to 30% is acceptable. So when you are starting an ACE inhibitor, then a decrease in GFR up to 25% or a rise in creatinine up to 30% is acceptable. Although any rise should prompt careful monitoring and exclusion of other causes like NSAIDs, a rise greater than this may indicate underlying renovascular disease. So renovascular disease means renal artery stenosis when you are starting an ACE inhibitor. So what is acceptable is 25% rise in creatinine or decrease in GFR up to 25%, rise in creatinine up to 30%. Questions have been asked around this same concept, doctors. That is why I am repeating it again. So furosemide is useful as an antihypertensive in patients with CKD, particularly when the eGFR falls below 45 ml per minute. Antihypertensive, furosemide, diuretic, antihypertensive when GFR falls below 45, that is 3B. It has an added benefit of lowering serum potassium. High doses are usually required. If patient becomes at risk of dehydration, gastroenteritis, then consideration should be given to temporarily stopping furosemide. The NFK DOQI guidelines suggest a lower cutoff of less than 30 ml per minute for furosemide, for starting furosemide in hypertension with chronic kidney disease. Which one of the following medical conditions Which one of the following medical conditions does not allow a patient to apply for a prescription exemption certificate? So we read this long time before. So which disease does not allow the patient for prescription exemption certificate is psoriasis, Addison's disease, diabetes, myasthenia, hypoparathyroidism. I think psoriasis, because we were thinking, poor fellow, he has to go for
Yes, psoriasis.
right? So they have no concern and no consideration for dermatology patients. The correct answer is psoriasis. A prescription exemption certificate in the UK allows certain individuals specific medical conditions to receive free prescriptions. According to UK guidelines, psoriasis is not one of these conditions, although it can be chronic debilitating. This condition requires ongoing treatment. Current regulations do not recognize as a disorder that qualifies an exemption certificate. Addison's disease allows a patient to apply for a prescription exemption certificate. This is because Addison's disease is a long-term endocrine disorder in which adrenal glands do not produce enough steroid hormones. Therefore, lifelong steroid therapy would be required for them. Diabetes insipidus also qualifies for exemption certificate. Diabetes insipidus is characterized by frequent urination, increased thirst due to antidiuretic hormone deficiency, or the kidney's response to it. Patients with this condition require constant medication intake, making them eligible for pre-prescription. Same for myasthenia gravis and hypoparathyroidism. Prescription charges. The following applies to England, Wales, and Scotland have abolished prescription charges. Who is entitled to free prescriptions? Children less than 16 years old, age 16, 17, or 18 in full-time education. So students. Elderly, age over 60 years. If the patient or their partner receives income support or job seekers allowance. Patient or partner receives income support or job seekers allowance if the patient has a prescription exemption certificate for any of the chronic illnesses. In England, there is no prescription charge applied to contraceptives, STIs, hospital prescriptions, medications Medications are GP administers. No prescription charge for contraceptives, STI treatments, hospital prescriptions, and medication or GP administers. Prescription exemption certificate. Just give me a minute, doctors. Women who are pregnant or have a child in the past are entitled to free prescriptions after issuing of a prescription exemption certificate. Patients who have the following chronic medical conditions are also entitled: hypoparathyroidism, hypoadrenalism for which specific substitution therapy is essential like Addison's disease, diabetes insipidus, other forms of hypopituitarism, diabetes mellitus except where the treatment is by diet alone, myasthenia gravis, hypothyroidism requiring thyroid hormone replacement, epilepsy requiring continuous anticonvulsive therapy, a permanent fistula requiring continuous surgical dressing or requiring an appliance. This is one of the surgical conditions. Rest were all medical. Undergoing treatment for cancer. This includes treatments for effects of cancer or for the effects of cancer treatments. Prepayment certificate. Prepayment certificate are for patients not entitled to free prescription but who receive frequent prescriptions. They are cheaper if the patient pays for more than 14 prescriptions per year. Question number 12. You're receiving some pathology results and come across the renal functions of a 73-year-old lady. Her estimated GFR is 57. 57 is grade 3. The rest of her results are as follows: sodium 140, potassium 33.6, urea 6, creatinine 87. All look fine. You look back through her notes and see that she had a blood taken as a part of her annual review 2 weeks ago and her eGFR was at 56. Only 2 weeks ago it was 56. Now it is 57. These current blood tests are repeated by another doctor. She takes 5 mg of amlodipine for her hypertension, but she has no other past medical history. You plan to have a telephone conversation with her regarding her renal function. What is the correct information to give this lady? So see, this is grade 3, right? So grade 3 is definitely CKD grade 3. And 2 tests have been done 2 weeks apart, and you have to plan what is the correct information you have to give this lady. This lady has chronic kidney disease. She needs no further test to diagnosis. This lady does not have CKD. If her eGFR remains below 60 on at least 2 occasions separated by 90 days, you can then diagnose CKD. If her urine albumin creatinine ratio is normal, she doesn't have CKD. If her eGFR remains below 60 on at least 2 occasions separated at least 30 days, then you can diagnose CKD. So which one is
Third question.
okay? 90 days is required, separated by 90 days.
Yes.
Okay, yes, absolutely right. So in order to diagnose CKD, you need your eGFR less than 60 on at least 2 occasions separated by at least 90 days. So in this case, the patient was done the GFR 2 weeks apart. So that does not count for that does not qualify for diagnosis of CKD. According to NICE, it's an abnormality of kidney function or structure that is present for more than 3 months with implications for health. Renal impairment associated with CKD can range from mild, where the patients have no signs and symptoms, to end-stage renal disease and the possibility of a renal transplant. CKD causes leakage of protein or blood into the urine. There are many causes of CKD. Commonly, it is caused by intrinsic diseases like diabetes and hypertension. Other causes are nephrotoxic drugs, obstructive kidney disease, or multisystem disease. The aim of early diagnosis and treatment is to decrease the risk of CVD, cardiovascular disease, and progression to end-stage renal disease. Therefore, we should be testing those with risk factors. In order to test for CKD, we need to take a blood to measure the creatinine level. This is used to calculate the eGFR. Send an early morning urine sample for ACR and dip the urine for hematuria. So, three things you have to calculate to check the kidney function. One is creatinine for eGFR, early morning spot albumin creatinine ratio, and dip test urine dipstick for hematuria. CKD is diagnosed when the tests have persistently shown a reduction in kidney function for at least 3 months or more or the presence of a proteinuria. See, either there is proteinuria or there is a reduction in kidney function for 3 months. This means eGFR is persistently less than 60 or ACR is persistently greater than 3 milligrams per millimole. This lady needs to drop an early morning urine sample in so that it can be dipped for hematuria and sent away for ACR measurement. She needs another blood test at least 90 days after the first one to confirm the diagnosis of CKD. Therefore, option 3 is the only correct answer. CKD is usually asymptomatic, generally diagnosed from the following abnormal urea and electrolyte results. However, some patients with undetected late disease may become symptomatic. So the symptoms are edema, ankle swelling, weight gain, polyuria, lethargy, pruritus secondary to uremia, anorexia which may result in weight loss, insomnia, nausea and vomiting, and hypertension. These are some of the symptoms of kidney disease. Which of the following secondary causes of hyperlipidemia result in predominantly hypercholesterolemia as opposed to hypertriglyceridemia? Diabetes, bendofluozide, nephrotic syndrome, alcohol, obesity.
Nephrotic syndrome.
Yeah, nephrotic syndrome will cause hyperlipidemia.
Hypercholesterolemia and hyperlipidemia.
Hyperlipidemia.
Three
Three
contain
conditions:
nephrotic
nephrotic
syndrome,
syndrome,
cholestasis,
cholestasis,
and
and
one
one
more.
more.
Three
Three
conditions
conditions
are
are
there.
there. Which cause hypercholesterolemia rather than hypertriglyceridemia.
Yes,
Yes,
yes.
yes.
Nephrotic
Nephrotic
syndrome,
syndrome,
cholestasis.
cholestasis. Very good, doctor. Hypercholesterolemia rather than hypertriglyceridemia, nephrotic syndrome, cholestasis, and hypothyroidism.
Hypothyroidism,
Hypothyroidism,
yes.
yes. The correct answer is nephrotic syndrome. Nephrotic syndrome is a kidney disorder that causes the body to excrete too much protein in the urine. This results in low level of albumin and increased lipoprotein production, leading to hypercholesterolemia, high cholesterol. The other forms of hyperlipidemia, such as hypertriglyceridemia, are not prevalent. Diabetes is an incorrect option. Primarily leads to hypertriglyceridemia rather than hypercholesterolemia. In diabetes, insulin resistance or deficiency results in decreased lipoprotein lipase activity and increased VLDL synthesis. This leads to elevated triglyceride levels. Bendofluozide is a thiazide diuretic used for hypertension, can indeed cause dyslipidemia. However, it typically raises both cholesterol and triglyceride levels rather than predominantly hypercholesterolemia. Alcohol. Chronic heavy consumption leads to both hypertriglyceridemia and hypercholesterolemia due to increased VLDL secretion and decreased lipid clearance. However, it's more associated with triglycerides than cholesterol. Obesity does not specifically result in predominantly hypercholesterolemia. It is associated with a range of lipid abnormalities, including elevated triglycerides, low HDL, and normal or slightly elevated LDL. Cholesterol levels due to insulin LDL cholesterol levels due to insulin resistance. In summary, while all these options can cause some form of dyslipidemia, only nephrotic syndrome is particularly known for causing predominantly hypercholesterolemia. Hyperlipidemia secondary causes. Causes of predominantly hypertriglyceridemia, diabetes type 1 and type 2, obesity, insulin resistant states, alcohol, chronic renal failure, chronic renal failure, drugs, thiazides, non-selective beta blockers, unopposed estrogen, and liver disease. All of this cause hypertriglyceridemia. Causes are predominantly hypercholesterolemia, nephrotic syndrome, cholestasis, and hypothyroidism. Good answering, doctor. A 40-year-old woman is diagnosed as having Addison's. What is the combination of medication she is likely to be prescribed? So she'll be prescribed a glucocorticoid and a mineralocorticoid. So glucocorticoid will be fludrocortisone, and good mineralocorticoid will glucocorticoid would be hydrocortisone, and mineralocorticoid would be fludrocortisone.
Yes.
Okay. Addison's disease management, hydrocortisone plus fludrocortisone, HF, not prednisolone. Addison's disease, known as primary adrenal insufficiency, is a condition where the adrenal glands do not produce sufficient steroid hormones. The main hormones that are deficient are cortisol and aldosterone. So hydrocortisone is used to replace cortisol, and fludrocortisone replaces aldosterone. This combination of medication helps to maintain a balance in these hormones in the body. So Addison's disease management. Patients who have Addison's disease are usually given both glucocorticoid and mineralocorticoid replacement therapy. This usually means that a patient taking a combination of hydrocortisone, usually given 2 or 3 divided doses, patient typically requires 20 to 30 milligrams per day, majority of them given in the first half of the day. Each one of these is an important point. So hydrocortisone, 2 to 3 divided doses, and majority 20 to 30 milligrams, majority given in the first half of the day. And then fludrocortisone. Just a minute, doctors. क्लास चल रहा है इनको लेके देखो कैसे सोते So, patient education is important. Emphasize the importance of not missing glucocorticoid doses. Consider medic alert bracelets and steroid cards. Patients should be provided with hydrocortisone for injection with needles and syringes to treat an adrenal crisis. And discuss how to adjust the glucocorticoid dose during an intercurrent illness. See below. Management of intercurrent illness. In simple terms, the glucocorticoid dose should be doubled with the fludrocortisone dose staying the same. This is also an important point. In addition, Addison's clinical advisory panel have produced guidelines detailing particular scenarios. Please see CKS link for more details. So anyways, from where I am living, neither the CKS links open, neither the NICE guidelines open. No, neither the BNF opens. So if there is anything important, if you can see, please share in the group. One of your patients with kidney disease stage 4 has annual bloods done. Hemoglobin is low, 9.4, platelets 166, WBC 6.7. Currently under renal team and has recently started on erythropoietin. What will the target hemoglobin be? So target hemoglobin for a kidney disease patient will be 10 to 12,
10 to 12.
9 to 11, 9 to 10, 11 to 13. 10 to 12?
Yes. Yes.
Okay. Ring Marisa. Yeah, 10 to 12. Anemia and CKD aim for 10 to 12 grams per deciliter. The correct answer is 10 to 12 grams per deciliter in patient with chronic kidney disease, CKD stage 4. The target hemoglobin is 10 to 12. The range has been established to balance the benefits of anemia treatment such as improved quality of life and reduce the need for blood transfusion with the potential risk associated with higher hemoglobin levels, including increased cardiovascular events. So, chronic kidney disease and anemia. Patients with CKD may develop anemia due to a variety of factors, the most significant one which is reduced erythropoietin levels. This is usually a normocytic normochromic anemia. Normocytic normochromic anemia becomes apparent when GFR is less than 35 milliliters per minute. Other causes of anemia should be considered if GFR is more than 60 milliliters per minute. So, anemia in CKD predisposes to the development of left ventricular hypertrophy associated with threefold increase in mortality in renal patients. So, causes of anemia and renal failure. Reduced erythropoietin levels, the most significant factor in CKD causing anemia. CKD is associated with decrease in production of erythropoietin, a hormone produced by the kidneys that stimulates erythropoiesis in the bone marrow. Reduced erythropoietin levels diminish red blood cell production. Reduced absorption of iron. Hepcidin is an acute phase reactant. In CKD, hepcidin levels are often increased due to inflammation and reduced renal clearance. Elevated hepcidin levels can lead to decreased iron absorption from the gut and impaired release of stored iron from the macrophages and hepatocytes, reducing the iron available for erythropoiesis. Additionally, metabolic acidosis is a common condition in CKD and can inhibit conversion of ferric iron to its absorber form, that is ferrous iron, in the duodenum and lead to reduced iron absorption. Reduced erythropoiesis due to toxic effects of uremia on the bone marrow. Anorexia, nausea due to uremia. Reduced red cell survival, especially in hemodialysis. Blood loss due to capillary fragility and poor platelet function. And stress ulceration leading to chronic blood loss. Oh my god, so many mechanisms for just reducing the hemoglobin levels in CKD patients. Management. In 2011, NICE guidelines suggest that target hemoglobin of 10 to 12 should determination of optimization of iron status should be carried out prior to administration of erythropoiesis stimulating agents. Oral iron should be offered for patients who are not on ESAs or hemodialysis. If target hemoglobin levels are not reached within 3 months, then the patient should be switched to IV iron. Patients on ESA or hemodialysis generally require IV iron. ESAs such as erythropoietin and darbepoetin should be used in those who are likely to benefit in terms of quality of life and physical function. Okay, so oral iron should be offered. So iron studies should be done, and oral iron should be offered first before giving ESA, erythropoietin. And for 3 months you have to give oral iron. If target hemoglobin is not reached, then patients should be switched to IV iron. In patient on ESA or hemodialysis, generally IV iron should be started. If you are in GP rotation, your administrative time during your administrative time, and while reviewing lab results, you come across these results belonging to a 56-year-old man. HbA1c 41, ACR is 71, GFR is 83, LDL is 2, less than 4 is normal. The patient has a recent visit to the center. His latest blood pressure was 135/80. His Q risk was 9.7. You checked his medications, found that he takes vildagliptin and amlodipine. What is your next step in the management? So Q risk is 9.7. No need to give etovastatin. Empagliflozin. Why you are giving empagliflozin? No heart failure. Enalapril, consider refer to nephrologist. Yeah, enalapril because ACR is raised, right? So AC inhibitor you will give and refer to nephrologist because ACR more than 70. Looks correct. Mark them as normal, check your next patient. Cannot be marked as normal. Refer the patient urgently to nephrologist. Maybe refer urgently to nephrologist would be appropriate.
No,
No,
third
third
option,
option,
doctor.
doctor.
Consider referral, enalapril and consider referral
Yes.
to nephrologist.
Yes.
Yes.
What is
What
the
is the
age
age
of the
of the
patient?
patient?
56.
Hello? 56. Hello, everyone.
Hi. You need to sleep, baby. So, third one. Maybe last one also.
Okay,
Okay,
we'll
we'll
mark
mark
last.
last.
I'm not sure. Okay, an ACR of more than 70 or more requires referral to nephrologist, but didn't say urgently to nephrologist. So requires a referral add an enalapril. Anyways, you have to add enalapril. Your revised answer is correct. Adding enalapril and considering referral to nephrologist is the appropriate next step in the management of patient with elevated ACR. ACE inhibitors are indicated in patients with diabetes and hypertension regardless of blood pressure, and referral to nephrologist is recommended for patients with an ACR of 70 or more unless proteinuria is known to be associated with diabetes and is managed appropriately. So this patient doesn't have diabetes, and vildagliptin, right? So he has diabetes. So since he is a diabetic, you have to add them an ACE inhibitor for proteinuria. So CKD and proteinuria. Proteinuria is an important marker of chronic kidney disease, especially for diabetic neuropathy. ACE inhibitors recommend using albumin creatinine ratio. NICE recommend using albumin creatinine ratio in preference to protein creatinine ratio while identifying patient with proteinuria as has greater sensitivity. For quantification and monitoring of proteinuria, PCR can be used as an alternative, although ACR is recommended in diabetics. Urine reagent strips. So ACR is used in diabetics, and PCR can be used as an alternative for other quantification. And urine reagent strips are not recommended unless they express a result as an ACR. So approximate equivalent values. ACR is 30 means PCR is 50. That means urinary protein excretion is 0.5 grams per 24 hours. And ACR is 70, PCR is 100, urinary protein excretion is 1 gram per 24 hours. Collecting the ACR sample. By collecting a spot sample, it avoids the need to collect urine over a 24-hour period in order to detect or quantify proteinuria, because ACR is a spot sample. Should be first pass morning urine specimen. If ACR is between 3 and 70, this should be confirmed by a subsequent early morning sample. If the ACR is 70 more, repeat sample need not be tested. Interpretation of ACR results. NICE guidelines regard a confirmed ACR of 3 milligrams per millimole or more as clinically important proteinuria. NICE recommendation for referral to nephrologist. Urinary ACR of 70 or more, unless known to be caused by diabetes or already appropriately treated. Urine ACR 30 or more together with a persistent hematuria. 2 out of 3 dipsticks show 1 plus or more of blood. So even persistent hematuria is, you need to do 3 dipstick tests and 2 should show 1 plus hematuria after excluding a UTI. Consider referral to nephrologist for people with an ACR between 3 and 29 who have persistent hematuria and other risk factors like a declining GFR or CVD. So all the 3 categories, 70 from 3 to 70, so have been ACR of from 3 to 70 have been categorized separately, and guidelines have been given for referral. So frequency of monitoring EGFR, number of times per year by EGFR and ACR categories for people with or at risk of CKD. I feel it's very difficult to remember, that if anyone knows any simple way, then it will be good if you share. So G1 category, G2 category, 1 times in a year, and G3 category also, G3 A1 and A2, 1 time in a year. G3 A3 is 2 times in a year. Excuse me. G3B and A1, A2, A3 will be 2 times in a year. G4 will be 2 times in a year, A1 and A2, and G4, A3 will be 3 times in a year. Excuse me. G5 less than 15 kidney failure, 4 times in a year you have to measure the GFR and ACR categories. Management. ACE inhibitors or angiotensin receptors are likely key in the management of proteinuria. They should be used first line in patients with coexistent hypertension or CKD if the ACR is more than 30. If ACR more than 70, they are indicated regardless of the patient's blood pressure. So They should be used first line in patients with coexistent hypertension, CKD, if the ACR is more than 30 and if more than 70. Regardless of the blood pressure, they should be used. SGLT2 inhibitors, patients who have proteinuric kidney disease, CKD, with or without diabetes, may benefit from treatment with SGLT2 inhibitors. They primarily act by blocking reabsorption of glucose in the proximal tubule and lowers the renal glucose threshold, glycosuria. By blocking the co-transporter, they also reduce sodium reabsorption. Natriuresis reduces intravascular volume and blood pressure, but it also increases the delivery of sodium to the macula densa, normalizes tubuloglomerular feedback, and thereby reduces the intraglomerular pressure. So, it helps by excreting glucose and thereby excreting sodium, and then sodium reaches the macula densa, and then there's normal tubuloglomerular feedback and therefore reduced glomerular pressure. So SGLT2 is indicated with or without diabetes in proteinuric CKD. Question number 17. Frederick is a 75-year-old man who has recently been diagnosed with chronic kidney disease and secondary to hypertension. He has come to see his GP for a review. On examination, his blood pressure is 135. He has no other past medical history of note. His 135 by 80. His recent investigations are as follows. Hemoglobin 135, sodium 145, potassium is 5, urea is 8.2, creatinine is 140, EGFR is 55, urine albumin creatinine ratio is 45, HbA1c is 44. He currently takes amlodipine, atorvastatin and ferrous sulfate. Which additional medication should be prescribed? Proteinuric kidney disease. So proteinuric kidney disease is there and BP is normal, proteinuric kidney disease, amlodipine, statin and empagliflozin. Where did it go? It's not here. So other options we have to see aspirin, bendoflumethiazide, ramipril, erythropoietin, metformin. Yeah, proteinuric kidney disease again ACE inhibitors should be prescribed, right?
Yes.
Ramipril.
I think renoprotective.
Yeah, that's true, but potassium is 5, huh? Ramipril. Erythropoietin is not required. Metformin, because HbA1c is 44. No. Ramipril. Patient with chronic kidney disease should be started on ACE inhibitor if they have an ACR more than 30 milligrams per millimole. This is okay, but there should be some caution with potassium levels when you're prescribing ACR. An ACE inhibitor is prescribed in patients with CKD and albumin creatinine ratio more than 3 milligrams per millimole if coexistent diabetes, or in ACR more than 30 milligrams per millimole coexistent hypertension, or in ACR more than 70. Okay, if 3 plus diabetes, ACE inhibitors, 30 plus hypertension, ACE inhibitors, more than 70, ACE inhibitors. Therefore, ramipril is correct answer. Bendoflumethiazide may worsen renal failure. Aspirin may be considered for secondary prevention of cardiovascular disease as per guidelines but not for primary prevention. Metformin would be indicated if there was a history of diabetes. HbA1c 44 indicates pre-diabetes but not require any treatment. Hemoglobin at the lower end of normal, therefore there is no evidence of renal anemia. Also, EGFR is 55. EGFR less than 30, then it is renal anemia. Otherwise, other causes of anemia should be ruled out. So we read this, and there's nothing new here. That's it. ACE inhibitors and prescription with high potassium should be revised once again. Which one of the following statements regarding angiotensin converting inhibitors is correct? They should be avoided in patients with history of hereditary angioedema. Yes. ACE inhibitors cause impaired glucose tolerance. Yes. No. They should be avoided in patients with chronic kidney disease stage 3 and 5. No, they should not be avoided, but there is some restriction. Dry cough occurs in around 1%. No, occurs in so much of very huge number of patients. Patient with mitral stenosis should be referred to secondary care for initiation of ACE inhibitors. No, why? Why particularly mitral stenosis should be referred to secondary care for initiation of ACE inhibitors? I think first, avoiding patients with hereditary angioedema because it causes angioedema also. What do you say, doctors?
Yeah,
Yeah,
first.
first.
Yeah. The answer is they should be avoided in patient with history of hereditary angioedema. Angiotensin converting enzyme inhibitors are contraindicated in patient with history of hereditary angioedema due to the increased risk of angioedema. And ACE inhibitors can increase the bradykinin levels, which can cause vasodilatation and increase vascular permeability. Present in patient with hereditary angioedema, this effect can lead to severe episodes of swelling. ACE inhibitors can cause impaired glucose tolerance is incorrect. ACE inhibitors do not impair glucose tolerance. In fact, they slightly improve it by increasing the insulin sensitivity and enhancing peripheral glucose uptake. Okay, they improve. And they should be avoided in patients with chronic kidney disease stage 3 and 5 is also incorrect. ACE inhibitors are actually recommended for people with chronic kidney disease stage 3 and 5, especially those with proteinuria, as they have been shown to slow the progression of kidney disease. Assertion that a dry cough occurs in 1% is not accurate. Incidence of cough associated with ACE inhibitors is much higher than 1%, typically reported to be 10 to 20%. This side effect is believed to be caused by accumulation of bradykinin in the respiratory tract. The statement patient with mitral stenosis should be referred to secondary care for initiation of ACE inhibitors is incorrect. While it's true that mitral stenosis requires specialist management, there is no specific guideline suggesting ACE inhibitors must only be initiated in secondary care in these cases. In fact, ACE inhibitors may be beneficial in some patients with mitral stenosis who have a heart failure or hypertension. However, the use should always be individualized and closely monitored due to potential effects on preload and afterload. So, ACE inhibitors, yeah, this one I wanted to read. ACE inhibitors are now established first line treatment in younger patients with hypertension and also extensively used to treat heart failure. They are known to be less effective in treating hypertensive Afro-Caribbean patients. ACE inhibitors are also used to treat diabetic nephropathy and have a role in secondary prevention of ischemic heart disease. Mechanism of action inhibits the conversion of angiotensin 1 to angiotensin 2, decrease angiotensin 2 levels to vasodilatation and reduce blood pressure. Decrease angiotensin 2 levels, reduce stimulation of aldosterone release, decrease in sodium and water retention by the kidneys. Renoprotective mechanism constricts the angiotensin 2 constricts the efferent glomerular arterioles. ACE inhibitors therefore lead to dilatation of the efferent arterioles, reduced glomerular capillary pressure, decreased mechanical stress on delicate filtration barriers of the glomeruli. This is particularly important in diabetic nephropathy. ACE inhibitors are activated by phase 1 metabolism in the liver. They require activation. So, in liver disease, there is a problem. Side effects cough occurs in 15% to 10 to 20% may occur up to 1 year after starting treatment, thought to be due to increased bradykinin levels. Angioedema may occur in up to 1 year after starting treatment again. Hyperkalemia, first dose hypotension, more common in patients taking diuretics. Someone who is taking diuretics, there will be first dose hypotension. Cautions and contraindications. Breastfeeding and pregnancy avoid. Renovascular disease may result in renal impairment. Aortic stenosis. So this is one thing which we have to remember, has been asked again in questions. Aortic stenosis may result in hypotension. So you should not give ACE inhibitors in aortic stenosis. Hereditary idiopathic angioedema. Specialist advice should be sought before starting ACE inhibitors in patients with a potassium more than 5.0. This is what I was thinking. In our patient, potassium was 5. So specialist advice before initiating ACE inhibitors in a patient with potassium more than 5. Interactions. Patient receiving high dose diuretic therapy more than 80 milligrams of furosemide significantly increases risk of hypertension. Monitoring. Urea and electrolytes, we already read about it, should be checked before the treatment is initiated and after increasing the dose. A rise in creatinine and potassium may be expected after starting ACE inhibitors. Acceptable changes are an increase in serum creatinine up to 30% from the baseline and an increase in potassium up to 5.5. Also, a decrease in GFR by 25% is okay. More than 25% suggests renovascular disease. Significant renal impairment may occur in patients who have diagnosed bilateral renal artery stenosis, that is more than 25% decline in GFR. So, and an increase in potassium up to 5.5 is tolerable. So, up to 5.5, you don't have to change the medicine. So, this was our hypertension management chart. I'm not seeing that again. So our class will end in a minute. 62-year-old man, this might be the last question for today. 62-year-old man with chronic kidney disease secondary to diabetes mellitus is reviewed when assessing the estimated glomerular filtration rate. Which one of the following variables may not be required in MDRD equation? So we just saw MDRD equation. What did you say, dear?
Last option.
Yeah, last option. Last option. Very quick. Even before I finished my question, you answered. You're absolutely right. Serum creatinine, age, ethnicity, and gender are required for MDRD equation. Best thing how you will remember is you just Google MDRD equation. Try to put in some values, maybe your old creatinine value, and put in your.